Hello, welcome to our latest installment of Reimagined in America. I'm Karobi Acharya, and I lead the Global Ideas for U.S. Solutions team here at the Robert Wood Johnson Foundation. I'm really excited about today's webinar and to hear from our two amazing speakers and to hear your questions for them. I know it's going to be a great conversation. So as a quick reminder, everyone's audio has been muted, but you'll be able to ask questions using the Q&A button on the bottom of your screen. And also as a reminder, we are recording the webinar today and we'll share the recording with you afterwards. So let's begin. There is no denying that we are swimming in data. By 2020, it's estimated that 1.7 megabytes of data will be created every second for every person on Earth. That blows my mind. For those of us bent on improving health and well-being, the question is, how do we make sure we get the most out of all this data? How can we make sure we're not just collecting data for the sake of it, but that we're building feedback loops where the data is getting into the right hands and is driving real change in our communities? As we scoured the globe for good ideas to help us build a culture of health, we found some answers to these questions. And in a few minutes, you'll hear about how the emergency room data help police in the United Kingdom curb violence, and how ordinary citizens in countries as diverse as Israel, Fiji, and Taiwan aren't waiting on scientists. They're stepping up to the plate to collect data in their own backyards and using it to solve urgent problems plaguing their communities. Police, residents, these aren't the type of leaders we're used to hearing from when it comes to health, and that's crucial. Today's health challenges are influenced by factors well beyond the clinic walls. It's going to take more than healthcare and public health professionals working in their traditional silos to build a culture of health, where everyone in the United States has a fair shot at living a long and healthy life. We're excited to share what we're learning with you today and to explore together how data can be used to empower unusual suspects to bring about healthier solutions for us all. But before we dive in, we want to do a quick poll to learn a little more about all of you. So you should be seeing a prompt on your screen with 3 questions, and just click on the answers. So the first question, and you may have to scroll down for the third question. So the first question is, why did you join today's webinar? So just click on your answer for that. The second question is, what is the best way to empower local leaders and advocates to bring about change in their communities? And again, you may have to scroll down for the third question. Have you ever shared or used data to catalyze change in your community? So please just click on your answers. Okay, last chance to vote. We'll give folks a few seconds to enter their responses. Okay, let's see the results. Well, let's see the results. We'll try that again. There we go. Great. So that's interesting. That first question, pretty, about half of you want to be inspired by ideas from other countries. Half also are looking for solutions you can use in your own community. That's interesting. Number 2, 56% of you said create a seat at the table, and sharing power is the best way to empower local leaders and advocates. And looks like a majority of folks have used data to catalyze change in your community. So that's great. I think we're in for a great discussion today with our 2 speakers. So let me introduce them now. So Dr. Stephen Sumner is a medical epidemiologist in the Division of Violence Prevention at the Centers for Disease Control and Prevention. With support from RWJF and the CDC Foundation, Dr. Sumner and his team helped bring the Cardiff model for violence prevention across the ocean from the United Kingdom to the United States. The model uses anonymous local data from emergency departments and law enforcement to help communities make informed decisions about violence prevention practices. Next, Dr. Abby King is a professor of health research and policy at Stanford's Prevention Research Center. At Stanford, Dr. King leads the Our Voice Project, a citizen science initiative that puts ordinary citizens in the driver's seat of identifying and collecting data on barriers to good health in their neighborhoods and communities, and then advocating for solutions. So I'd like to kick things off by asking Stephen and Abby a couple of questions, and then we'll turn it over to the audience to ask questions. And as a reminder, you can enter questions in under the Q&A button on your screen. So let's get started. So my first question is to both of you, and maybe Stephen, if you want to go first. How can data help catalyze action and drive community engagement and leadership?
Well, thank you so much for having me in this conversation with you all today. Here at CDC's Division of Violence Prevention, strong community engagement is something we're always trying to promote. And there are a couple of really big challenges when it comes to violence prevention. One of those challenges is that most violence that happens in communities is hidden. And what I mean by that is that cities typically make most of their violence prevention planning decisions based on official police data. But we know that most violence that happens is not reported to police. Another major challenge in the field of violence prevention is that oftentimes in a city you have many individuals and organizations trying to solve the problem of violence. Entities like hospitals and public health departments, police departments, domestic violence shelters, business groups, local community leaders, churches, and so on, but each of them only having access to a limited picture of the problem and also limited resources to solve the problem. So one of the big promises, I think, of better approaches to the use of data or information in helping communities is that, number one, it can help them understand the problem in more complete ways. And then number two, I think data is something that can be used to bring together diverse partners to talk about the information and reflect on it.
That's great. Thank you, Stephen. Abby, would you like to tackle that question?
Sure, Karobi. Thanks so much. It's really great to be here. Our group has found that decision makers and service organizations typically really do understand the importance of obtaining data both about and from residents, but there's often a gap in knowing how best to do it in a systematic yet practical way. And so to address this gap, we've been testing what we call a citizen science by the people approach. This approach blends the standardized resident-based data collection methods that are a hallmark of typical citizen science with the active resident engagement of community-based participatory research. And we find this typically leads to a more authentic form of engagement that can drive relevant community change. We think of it as a bottom-up data and action approach, which can complement top-down policy and institutionally focused approaches to community data collection. And it taps into arguably the most underutilized renewable resource on the planet to promote health and human wellness. And that is the power of residents themselves to collect data and use those data to help build solutions. And this kind of by the people approach really differs from other citizen science approaches that typically involve residents in collecting information or donating their own health data. But they often leave the resident out of the loop when it comes to question development, types of data being collected, and the uses of the group level data that the citizen scientists collect. So in our conversation today, I'll be describing a particular type of citizen science by the people method called the Our Voice Global Citizen Science Initiative, which involves both qualitative and quantitative data gathering, and it aims to empower residents to become positive catalysts for meaningful and sustainable health promoting change in their communities. And I'd like to invite each of you who are listening to the webinar to think about how this type of approach could really help to advance the goals of your own work. Thanks.
That's great. Thanks, Abby. So turning back to you, Stephen, you helped Georgia's DeKalb County adapt the Cardiff model, this violence prevention model from the United Kingdom. Can you tell us a little bit about how the model works and what is the role of community members in that?
Yes, absolutely. At CDC, as you mentioned, we've been supporting a pilot project here in Georgia trying to replicate or bring to the U.S. a very successful violence prevention program that's done in the United Kingdom. That program began decades ago in Wales and is called the Cardiff model. It's named after the city where it started. And essentially, individuals there long ago realized, very similar to the challenges that we face in this country, that they also had an incomplete understanding of where violence was happening in their community, and they also needed to find better ways to coordinate across all the different people and organizations that were working to prevent violence. So the Cardiff Model program was born there, and in this program, quite simply, information about where and when violence occurs is collected, both from the emergency department as well as in standard police reports. And then this anonymous information from both sources is combined and mapped, and these maps allow a community prevention board to decide where to implement prevention solutions. And in the city of Cardiff, the results have really been striking. The approach has led to a more than 40% decrease in hospital admissions due to violence. And in the city of Cardiff, the data that is being used to inform their efforts has been used by the community board to really inform and implement a very wide range of creative interventions. Everything ranging from switching over glass barware to plastic, pedestrianizing certain streets, or altering the built environment in beneficial ways, improving visibility around high crime areas, and much more. And so the model really gives partners a data-driven way to act, and also brings them together to talk about the data.
Great, thanks so much. Abby, the Our Voice project that you're leading at Stanford is empowering ordinary citizens to identify barriers to health and well-being. So tell us a little bit about how it works and what are some of the impacts that you've seen.
Sure, Karobi. Yes. And there should be a slide. There it is. Okay. Our Voice is a 4-step process to help residents discover, discuss, advocate for, and change their local environments to improve health and well-being. And it starts with an easy-to-use mobile app called the Discovery Tool. This type of app can be used by residents irrespective of tech literacy or language to assess community features that either promote or hinder healthy living via geo-coded route tracking, geotagged photos, and audio narratives, and we have them integrated through a web portal. And this app has been translated thus far into 8 languages and counting. So once residents use the app, then in a facilitated process, they share their photos and their stories together and build consensus for important yet feasible areas of change. And typically, residents are working in small groups of about 8 to 10. There are some remotely trained facilitators that help to augment this process and keep it going, and they've come from all sectors, including health, government, nonprofits, funding organizations, as well as residents themselves. The residents then share their data with key decision makers, and together they develop possible solutions, and they become active, informed participants in activating local changes. And this method is successfully being used right now with residents anywhere from ages 9 to 90 in over 16 countries on 6 continents. And in terms of just some of the impacts from Our Voice, We've been working, for instance, with Girl Trek, a national grassroots organization of African American women in 8 U.S. cities, where they've provided local civic leaders with relevant data pertaining to walkability and safety. For instance, in Girl Trek in Denver, the residents were able to work with officials there to promote new signage and sidewalk repairs in a major pedestrian route. In Anchorage, Alaska, meanwhile, old LGBT residents identified and shared barriers and enablers of safe and welcoming places throughout Anchorage with local organizations. And interestingly, as part of that citizen science process, the residents' sense of social cohesion significantly increased and loneliness scores decreased. We've seen positive changes in Israel and the US around increased age-friendly walking routes to destinations. And in terms of school environments, we've seen increased walking, biking to school in a US project, as well as healthier school environments in Colombia. Also in the US and Colombia, there have been local park improvements to increase community physical activity, as well as great park utilization in lower income neighborhoods. And in the US, we've also seen how seniors can successfully advocate for local community gardens near their housing, as well as more direct access to healthier foods.
That's great. Thanks so much, Abby. Stephen, just going back to the Cardiff model, tell us a little bit about how that's been received in DeKalb County. What impacts are you seeing there?
Well, we've really seen a very positive reception to the approach here. The local police department, as well as Grady Hospital, are working closely together with the health department and key members of the local community. And one of the great things about the Cardiff model that I've seen is how it brings together people and organizations who perhaps all work on violence prevention or one aspect of it, but haven't had the chance to really partner with each other in robust ways in the past. The other thing I want to mention is that I think the information that the partnership generates really adds value. We did a formal statistical evaluation that was recently published in JAMA Internal Medicine, and that study found that over 3/4 of violent injuries that were being treated in the emergency department weren't known to the city. So there was a gap in knowledge about where violence was happening. Although we're still very early in the process of piloting and replicating the Cardiff model, community and business leaders have already begun to use this information to try and better guide programs in their neighborhoods, things like community gardens, where hunger may be a major issue behind crime, or improvements in beautification and visibility that really make a difference in communities.
Yeah, that's really interesting. Thank you. Thank you, Stephen. So Abby, last question to you before we turn it over to questions from our audience. And again, as a reminder, if you have a question, please enter it into the Q&A box at the bottom of your screen. Abby, I know you're seeing some really interesting ripple effects from the Our Voice project. Tell us about some of those.
Yes, Karobi, this is one of the most exciting parts of the project for us, is really watching how residents who've never had a voice before can actually become change agents, and how that process has enhanced their personal and group efficacy and led to future advocacy efforts. So, for example, here on the screen is one such ripple effect. It started with low-income adults in northern San Mateo County, California, who were focusing originally on healthier food environments for low-income residents, and they were able to make some nice changes in those areas. And then we discovered 9 months later that these same residents had formed a senior advocacy team, and they had met with policymakers about a dangerous street segment near their senior housing, and they were actually able to get new street signage and parking restrictions. And then 12 months later, lo and behold, we heard about another kind of ripple effect, and that these seniors had gone to the state capitol to advocate for affordable senior housing. And then 24 months later, they had partnered with a nearby school to address speeding drivers. And an outcome of that was that the city installed some pedestrian signals, crosswalk modifications that benefited both the seniors as well as the children on their way to school. So our question is, what's next? Residents are becoming community leaders and advocates for health. So just to share a couple more of these types of ripple effects, in one of our senior housing projects in an affordable public housing site in East Palo Alto, California, the original goal had been to improve healthy physical activity and food environments. And one of the initial outcomes of that project was that the voices of these citizen scientists were actually incorporated into a senior advisory committee resolution, which was working on identifying a range of issues related to active living. But it didn't stop there. We found out that over the next 24 months, the city actually appropriated $400,000 for an environmental analysis. They revised and repaired streetscapes and sidewalks. They improved access to the local senior center that the seniors had been asking for. And they received a grant to update the general plan and zoning code so that public health was for the first time targeted in future planning in that city. In Bogota, Colombia, we've been seeing some incredible things in terms of the building of new pathways between new multi-sector, multi-setting collaborations around citizen science. The work there started with citizen science activities among researchers and civic partners and residents, focusing on citywide open streets programs, their Ciclovia program. And these kinds of partnerships have really been expanding into new partnerships among researchers and residents, as well as decision makers in areas related to schools, parks, food markets, and a new transit system to impoverished areas of Bogota.
That's great. Thank you so much. And like I said, we're going to turn to some audience questions. We did just want to highlight that, and Stephen, maybe you can say a word a bit about the toolkit that you've just launched, and then we'll go to the audience questions.
Absolutely, thank you. Standing up partnerships among diverse organizations that share data, and trying to translate programs from the global setting to the US can have unique challenges. And so one of the last things I wanted to mention about the Cardiff model is that CDC has put together a toolkit of information that can help communities and cities who are interested in implementing the Cardiff model. It includes a video, guidance documents, infographics, and more, and can be easily found on the CDC website. Questions about the Cardiff model can also be emailed directly to us at cardiffmodel@cdc.gov.
That's great, thank you. And along those lines, let's turn to one of the questions. So we have a question for you, Stephen. The question, I'm going to paraphrase a little bit because it's a long question. But the question is, what about the lawyers? We've had great difficulty getting the lawyers on board in terms of, I think a lot of the data privacy issues and liability law, things like that. Do you have anything that might help the lawyers and their elected and corporate leaders they work for find the way to data sharing solutions?
Absolutely, and this is one of the reasons why CDC drafted and published our toolkit for the Cardiff model. One of the guidance documents in there specifically provides information around data sharing and how it can be done in an appropriate manner. One of the things that we haven't talked a lot about yet in this webinar, but is really key, is the important role of public health agencies and public health departments. They're a key convener in the Cardiff model, and they also allow data to be shared and combined from diverse agencies in a privacy protecting way that's compliant with legal and regulatory standards that are absolutely important to consider.
Great, thank you. Abby, a question for you. What are some ways that you are marketing this tool, and how do you get residents to engage? And I think perhaps a little bit of a corollary question is, does the app collect demographic information from those that participate? And I would imagine that you know, there are implications to collecting that kind of information in terms of engagement. So talk a little bit about that.
Yes, thanks. The app can be adapted in whatever way in terms of the kinds of data related to demographics that are being collected. We've purposefully kept it not that specific when it comes to demographics, because there are a lot of places where people really don't want to share that kind of information. And so our basic platform is quite simple, and we wanted to keep it simple, and so that people who have never touched technology, people who have never been part of data collection, would see it as a friendly sort of app and wouldn't be scared away. Many of our partners would love to have that kind of data, and so what they do is they just append other kinds of questionnaires onto it. So it's really sort of a basic platform upon which those kinds of data can be additionally collected. So we do have participants in various projects collecting demographics as well as other kinds of social data, but not in all projects. And again, we wanted to keep things simple. In terms of marketing, a lot of people have found us on the website, and we as well have been working with various kinds of organizations around the world as part of our global network. Again, we're in many different places in the world, and we've had pathways from different kinds of organizations to us. Some of them have been academic research organizations working in communities. Others have been national nonprofits and funding organizations. So that's really has varied, and the ultimate goal is for us to make this a worldwide platform, which we do have a web portal and that, and I'll discuss that, I think, in my closing remarks. But, we are looking to make partnerships with diverse groups around the world.
That's great. That's great. So we have another question here, I think for both of you, and maybe Stephen, if you could go first. The question is, has your process been used in rural communities? And if so, how?
Well, I think one of the really important and encouraging things to note about the Cardiff model is that it's perhaps easiest to implement in small and mid-sized cities, where that may be more similar to the original city of Cardiff in Wales, where essentially there was one main hospital and one police department who initially formed a partnership. So in small cities where the number of hospitals and the number of law enforcement agencies are limited, it's easier to get collaborations like the Cardiff model up and running.
That's great. And Abby, how about Our Voice? Has that been used in rural areas?
Yeah, that's a great question, because we all know that rural areas tend to sometimes be underutilized or under-focused on. So yes, we have been watching Our Voice being used in rural parts of the state of Missouri and California, as well as overseas in South Africa, more rural parts of Israel. We are currently working with some German colleagues who have some very small little communities in Germany who tend to be underserved, and they are working on developing projects there. So the thing that we have tried to do with this model is make it as flexible and as adaptable as possible, both in terms of the kinds of questions that communities want to go after and hear residents' voices about, as well as locations and populations that can use it.
That's great. Thank you. So I have another question, I think for both of you. And Stephen, if you want to go first, the question is, how can healthcare providers support your efforts? The specific role of healthcare providers.
Well, that's a great question. And in the Cardiff model, of course, healthcare providers play a really important role. In fact, the Cardiff model was initiated by a healthcare provider, Dr. Jonathan Shepherd, to try and address the large amounts of violence that he was treating in the emergency department in Wales. I think there's an important role for healthcare providers to express interest and advocate for doing more violence prevention work in the settings in which they practice. And the Cardiff model is a great pathway or a plan for how they can do that, and more easily collaborate with the kind of diverse community partners that they would be interested in working with.
Great, thank you. And Abby, how about you, healthcare providers?
Yes, people are often patients. They have connections with their healthcare provider groups, and healthcare providers are typically asking them to make changes and directing them to change their own health and their own health behaviors. But they oftentimes are doing this without really understanding the context in which your patients live. And so I think these kinds of tools, the Our Voice method and these kinds of tools, really provide a means for allowing patients to actually capture their contexts and why is it difficult to lose weight and what's happening with their physical activity or their smoking cessation, and to really provide that kind of additional information that they can then share back with their healthcare providers. And I really see this as future of healthcare, is that more and more healthcare is going to live out in communities beyond the walls of clinics and hospitals, with all of the technology-based advances that are being made in the world. So this is just one example of how technology, simple technologies, can really bring the context that patients live, work, and play in on a weekly basis back to their healthcare providers.
That's great, thank you. Another question for you, Abby. How does Our Voice define social cohesion? Well, this is, yeah, we'll just say, how does Our Voice help to define social cohesion?
That's a great question. And I think what we've been finding, so one goal of the Our Voice Global Network is to share around the world different ways of capturing these constructs: social cohesion, loneliness, a lot of well-being constructs. And what we're trying to do is develop a repository of different methods and means of collecting and defining those constructs as a first step to better understanding what people mean, because they're complex, and it really depends on what tool you're using, what survey you're using. And so our first step is to really develop this repository in terms of really gathering around the world ways of identifying and measuring these kinds of constructs. And then hopefully we can move forward in identifying some core truths around these constructs that can then be used in a standardized way around the world.
That's great, thank you, thank you. Another question for both of you. So here the question is, you've seen community engagement in action in countries around the world. What's your biggest piece of advice for other groups looking to use data to engage community members? Sorry, Stephen, if you, yeah.
Yes, I'm happy to start. Well, we've really seen data in a very positive way help bring people together and sustain partnerships. I think data helps because it's objective, and then I think it's also In the case of the Cardiff model, as I mentioned, it provides useful information or perhaps new information that didn't exist before that people can use to make really concrete decisions. And as I also alluded to in the past, however, standing up new partnerships and in trying new programs that use data in an innovative way can have their unique challenges. And for example, that's why we work so hard with the Cardiff model to put together this toolkit or guidance documents to help answer a lot of the questions communities or cities may have as they go through thinking about how to adapt something like the Cardiff model to their context in the U.S., whether that's urban or rural or whatever the context may be.
That's great. Abby?
Yeah, I think to really, the key thing that you're hearing from me today has to do with really engaging community members directly in relevant yet easy to do data collection. And what we've discovered is that simple technologies can be a gateway for really reaching all kinds of people, including those that have never touched technologies before, like smartphones or iPads. And so I think making data collection fun and accessible can really be a hook to attracting interest and attention, and it can actually turn residents from being bystanders when it comes to their health and what's happening in their communities into actually leaders for positive community change. So I think data gathering tools that are qualitative as well as quantitative are really important, that are fun, that can be used with just a little bit of training, are a wonderful tool that we have found. And we too have toolkits and things like that to also help people be able to utilize and access this kind of our voice method.
That's great. That's great. Question for you, Stephen. It would seem to me that survivors of violence have a lot of complex reasons for choosing not to report to law enforcement. Are there concerns about unintended consequences, for example, in terms of over-policing in certain communities or regions of using this model? Unintended consequences.
That's a great question. There are many reasons for why violence is not reported to police. In fact, it's something that's studied periodically in a large national survey called the National Crime Victimization Survey. As I mentioned, there's many reasons individuals may not feel that reporting the violence may help them, or there may be other concerns. One of the important things to note about the Cardiff model that hasn't been mentioned yet is that it's primarily focused on violence, or exclusively focused on violence that happens in public places. So no information about violence that happens in private residences or other locations like that is used in the model. This is really meant to help communities understand in public places where is violence happening and what can they do to better address violence there. And the other thing that's important to say is that in the Cardiff model, all the information that is used is anonymous or general information about where violence is happening in communities, and not specific or identifying to any person.
That's great. Thank you. Abby, a question for you. Have you seen anyone use the Our Voice tools in disaster risk reduction, preparedness, and response yet? And if so, what has worked well?
That's a great question. A few years ago, we started a few conversations with the Red Cross, and then we weren't able to move forward. But I think the time is ripe to do that. And we actually have recently been connected to groups overseas that are very interested in the refugee situation and other kinds of situations that are becoming increasingly common. So I don't have anything to report right now on that, but we're preparing to see how groups can move into those areas to really better be able to understand how getting residents' voices on board can help to develop solutions in those areas. And I just want to piggyback a little bit on what Stephen's been talking about in terms of violence prevention. We have, and there have been some projects using our voice methods around violence prevention, especially on college campuses. I think everybody knows how that has become a real hot point these days in terms of what's happening across the U.S. on college campuses. And so far, it's been encouraging in terms of the students really using these kinds of methods to identify safe and comfortable spaces and places. And I think, again, it's an example of how this bottom-up approach can really complement the kind of more top-down institutional level approaches that Stephen's been talking about.
Great, thank you so much. So my last question is to both of you. And the question is, how do each of you promote and share these models with others, aside from webinars like this? So yeah, please, and I should note that when we send out the link to the recording, there will also be links to some resources on both our voice model and the Cardiff model, including the toolkit. But if you could each just say a little bit about, how you're sharing the models and encouraging others to use them. Stephen, you want to start?
Sure. Well, the Cardiff model has really, as we've observed, had a wonderful history of expansion from where it began in Wales, subsequently expanding to the rest of the United Kingdom. It's a program that's been tested out and implemented in different countries around the world, including South Africa, the Netherlands, Australia, and more recently, through the Robert Wood Johnson Foundation support, being tested out in the United States. And at this point, at CDC, we've worked to talk about the model in a number of different ways, scientifically through scientific publications, and then also word of mouth communications, as well as presentations at important conferences and events like this. As I mentioned earlier, we're also happy to answer questions from specific communities that want to understand more about the model and that would like to email us directly at cardiffmodel@cdc.gov.
Great, thank you. Abby, how do we find out about Our Voice?
Yeah, well, the first easy step would be to go to our website, which is ourvoice.stanford.edu, which tells a bit about our origin story and where we are now in terms of our global network and all of the different projects that are going on, as well as our publications. Our network has been our best resource, our global network. And we've tried to get the word out through publications and presentations. The information often will sit on other groups' websites, and people have found us that way. Some of our partners have blogged things. For instance, Girl Trek, our Santa Clara County Public Health Department group, and others that are in the community oftentimes have used blogs and other sorts of online kinds of communication. So all of that is working, and obviously a webinar like this is a wonderful way too for us to try to get out the word a little bit more to as many different sectors as we can, because ours is definitely a multi-sectoral focused kind of initiative.
Wonderful, thank you. So I'm afraid that's just about all the time we have for questions. I've really enjoyed hearing the conversation around how data has acted as a gateway to better health around the world, and how your projects are taking off in the US. I wish we had more time, but it seems we're in clear agreement. Data is a powerful tool and a crucial ingredient for improving health and well-being. But we benefit from it most when we get it into the right hands and create those feedback loops. I think about one of the most important feedback loops in my own life is the traffic app Waze, built on the data of its users. And having that real-time data helps me navigate the wonders of New Jersey traffic and get to work on time. But we all have a responsibility to help local communities to rise up to this challenge, to build their power by sharing data, by facilitating sector-spanning partnerships, and generating new models of citizen engagement and action. So I hope you've come away from today's conversation with some ideas for how to get started in your community. As soon as we're done, a very short survey was going to pop up on your screen. Please take a moment to fill it out and let us know what you thought of today's webinar. And look out for an email with a recording of today's discussion, and we hope you'll share it far and wide. So with that, I'd like to say thanks to Stephen and Abby and to everyone who joined us today. I hope to see you on the next Reimagined in America webinar. Please fill out the survey and have a great day.